Welcome everyone. My name is Dorina Greff, and let me present my progress report on preconceptional, gestational and postpartum carbohydrate metabolic disorders. My vision to increase fertility and complication-free pregnancy rate, and my mission to achieve my vision by novel prevention strategies and to improve carbohydrate metabolism. Currently, we are working on 3 projects about the inositol treatment in polycystic ovary syndrome and gestational diabetes mellitus. In the first meta-analysis, we are investigating the safety and efficacy of inositol and metformin treatment in polycystic ovary syndrome. PCOS is one of the leading causes of infertility, and its prevalence was about 5 to 20%. The main characteristics of the disorder is polycystic ovaries on ultrasound examination, hyperandrogenism, and ovulatory dysfunctions. Up to 60% of women with PCOS are also overweight. The pathogenesis is unknown. However, insulin resistance presents in 75% of lean and 95% of overweight women. Metformin is commonly utilized to reduce this insulin resistance. However, it has some gastrointestinal side effects, such as nausea, diarrhea, and vomiting. That's why another medical option is needed, which can be inositol. According to an Australian guideline, inositol can currently be considered as a complementary therapy in PCOS, with emerging evidence on efficacy highlighting the need for further research. That's why our aim to examine the potential beneficial effect of inositols in the treatment of PCOS. The clinical question was that, are inositols efficient and safe in the treatment of PCOS? The population is women with PCOS. Intervention was inositol, comparators were placebo or metformin, and our primary outcome was presence of ovulation and the cycle length. The secondary outcomes were BMI, pregnancy rate, carbohydrate metabolism, and clinical and laboratory hyperandrogenism and side effects. Our hypothesis is that inositols are non-inferior compared to metformin regarding the presence of ovulation and cycle length. After the systematic search, at the end of the full text section, we found 26 eligible articles. Now let's turn to the results. Our primary outcome is cycle normalization, and we found 2 eligible articles comparing inositol treatment to placebo, suggesting that in the inositol-treated group, patients has almost twice more likely to have a regular menstrual cycle compared to placebo. We also compared it to metformin, where we found non-inferiority. In the next few slides, I would like to summarize the results of studies comparing inositol treatment to placebo. The colored those rows where significant results were found, and the colorization meant to highlight the quality of evidence. In case of BMI, we found 8 eligible articles suggesting that inositol has beneficial effect on weight loss. Regarding androgen profile, inositols can significantly decrease total and free testosterone and androstenedione levels, and inositols can significantly increase sexual hormone binding globulin levels. We also investigated the carbohydrate metabolism, where fasting plasma glucose and area under the insulin curve was significantly decreased by inositol supplementation. In this table, we summarize the results of studies comparing inositol treatment to metformin, and we found non-inferiority in almost all of the cases except 2. One of these was sexual hormone binding globulin, where inositols were proved to be better, and the other outcome was Ferriman-Gilbey score, where metformin was proved to be better. The strength of our study is that we not just compared inositol treatment to placebo, but also to the gold standard treatment, metformin. And we investigated the different inositol stereoisomers on plenty of outcomes. The limitation were the small number of studies with small sample size, a variable follow-up time, and the included studies administered different dosages of inositols. The implication for practice would be that inositols are effective therapeutic approach in PCOS, and they might be considered as a non-inferior treatment compared to metformin. Implication for research would be that further RCTs are needed with bigger sample size to assess the effect on pregnancy rate more accurately. And the possible additive effect of metformin and inositols co-administration should be examined. With this figure, I would like to present the role of insulin resistance and hyperandrogenism in the pathomechanism of PCOS. And based on our meta-analysis, the following factors can be influenced by inositol supplementation. It can reduce BMI and insulin levels. It can increase sexual hormone binding globulin levels, decrease serum total and free testosterone levels, and inositols may improve ovarian function. To summarize it, inositol treatment has beneficial effect on several parameters of PCOS, and in the most relevant outcomes, inositols showed non-inferiority to the gold standard treatment, and this suggests that inositols are promising alternative treatment in PCOS, especially for those who suffered from side effects from metformin. We submitted our manuscript to the Journal of Translational Medicine. And let me introduce my second meta-analysis about investigating the efficacy of inositol administration in the prevention of gestational diabetes mellitus. GDM is the most common endocrine disorder related to pregnancy. It affects 7% of pregnancies globally, and it can cause several maternal and offspring complications, such as macrosomia, jaundice, and in long term, mother who suffered from GDM has 10-fold higher risk for developing type 2 diabetes mellitus and 2-fold higher risk for cardiovascular events. Despite of these facts, there's no medical treatment is generally prescribed for the prevention of GDM. And as I mentioned earlier, inositols are great insulin sensitizers. That's why our aim to investigate the preventive effect of inositols in the development of GDM. Can inositol treatment prevent the development of GDM in pregnant women? That was our clinical question. And the population was pregnant women, intervention, inositol. Comparators were no intervention or placebo. And our primary outcome was the GDM diagnosis by the time of oral glucose tolerance test. The secondary outcomes are need for insulin treatment, the results of OGTT, and maternal and fetal complications listed on this slide. Our hypothesis is that inositols can decrease the incidence of GDM compared to placebo or no intervention at all. After the systematic search, we found 11 eligible articles. Our primary outcome is GDM, and you can see on this plot that the incidence of GDM is significantly lower in the inositol-treated group compared to placebo. And if GDM develops, the second most important question is the need for insulin. And here you can see that the need for insulin treatment is also significantly lower in the inositol-treated group. And inositol treatment also can reduce the risk of preterm birth too. The strength of our study is that we investigated different inositol steroisomers on plenty of outcomes, and the limitations are the lack of blinding methods in the included RCTs, and they are mostly included Caucasian women. So we can conclude that inositol treatment reduces the risk of GDM compared to placebo or no intervention at all at high-risk population. And if GDM develops despite the inositol treatment, it still reduces the need for insulin or preterm birth. Currently, we are focusing on this manuscript to finish it. And based on our second meta-analysis, we are planning to do protocol of a randomized trial too. Let me finish my presentation with a quote from Bill Gates. We all need people who give us feedback. That's how we improve. Thank you for your attention.
No, I'm just asking actually, I mean, when you saw your first part, then I formed a question, and then you actually put that down in your conclusions or kind of indications for research that inositol and metformin should be combined, because that may be actually have a very, I mean, much better outcome. So is there any data on those combination, or this is just coming from your research?
No, there are some RCTs about the combination of these two, but the number of these RCTs were not enough to make a meta-analysis or to make a network meta-analysis, because this was our original plan, to make a network with these two too.
Because, I mean, many times actually this kind of combination treatment could have an even stronger and better results. So good luck for that.
Yes, it's true. Thank you.
I'm just wondering, it's very, very recently there is a publication regarding that male population as a prevention of prostate cancer, where the metformin together with testosterone plays an important role. Do you know whether is there any role in metformin or inositol regarding the hormonal status of these women? Might it play any role? I mean, because I was very much surprised that it's together. It's very, very important in male. Do you think whether?
I think the connection is the insulin resistance, because these also metformin and inositols are effect on insulin resistance, and the connection will be between the if there is an insulin resistance, then sexual hormone binding globulin producing in the liver will be lower. And if you can solve this insulin resistance, then the sexual hormone binding globulin producing in the liver will be higher, and there will be much less free testosterone level.
I couldn't agree more. So that I think this is also my hypothesis to prove it. So Dorina, thank you very much and congratulations again.